to life, in the worst scenario, to the patient. It is one thing that most of us healthcare workers dread, and it can actually increase hospital stay. It can adversely affect patients' quality of life later on, and some infections have been known to produce lingering effects, and some can lead to reoperations with their own attendant risk. And in fact, surgical site infection can introduce infection in settings of health insurance, care. When you have healthcare insurance payment, because payments have been estimated, bills have been estimated for primary surgery. Now you are getting complications coming in, and that can cause a lot of confusion and make the costs to be very, very varied between individuals. Strict adherence to prevention guidelines have been shown in studies to significantly reduce the risk of surgical site infections. Every surgical team member is a player in this regard. Everyone. I hope we have such a spread here, ranging from the anesthesiologist to surgical theater technician, to the anesthetic technician, to the perioperative nurse, the surgeon, to even the porter and the cleaner. Everybody has a role to play in this. What exactly does the healthcare worker want to happen to a surgical incision site? I believe the image on the right is not what many of us desire. We don't desire to see that image on the right. So this discourse is timely. Definition-wise now, clinical definition describes surgical site infections as infectious process present at the site of a surgery. That's as simple as that, right? Presence of signs and symptoms can actually, further corroborate this definition. Signs of inflammation and infection, redness, heat, pain, and exudates from the wound site, or exudates from the wound or a drain that is placed, intraperitoneal drain that is placed. The Center for Disease Control reporting definition for surgical site infection defines it as infections occurring up to 30 days after surgery, or up to 1 year when surgery involves, the use of implants, and affecting either the incision site or deep tissue at the operation site. According to the range of affected tissues, surgical site infections can be considered under 3 classes: superficial, deep, or organ space specific sites. Other terminologies have been used to describe surgical site infections in the past. Wound infection, for instance. And as regards minimally invasive or minimal access surgery, laparoscopy, we talk about port site infection or port-related infection. Surgical site infections have been found to contribute up to 18% of healthcare-associated infections. As high as that. As high as 1/3 of patients undergoing surgery have been reported by WHO to have one form of surgical site infection or the other. Many of the reports we are having give a range of 2 to 15% of surgical site infections, but these are mainly hospital-based reports, as in patients who actually present to the hospital. The incidence may be underestimated, as most, over 50%, are observed after discharge from the hospital. The hospital-based study reports a case fatality rate of 4.5% in patients who had surgical site infections. What are the determinants of infection, of the wound site or the surgical site? The type of the surgery, the type of the wound. Is it a clean wound? Is it a contaminated wound? The site of the surgery. Are we talking about deep tissue? Are we talking about tissue areas where we have exposure to hollow viscous, or exposure that are normally colonized by microorganisms which could become pathogenic? What type of surgery was done? Is it minimally invasive surgery? Minimally access surgery has lower infection rates than open surgeries, as low as 8 to 9% compared to higher in open surgeries. And the indication for the surgery also is important. Patients or interesting factors like age, obesity, some of which they are not modifiable, use of steroids, debilitating illness, malignancies, tobacco use, and other extreme factors like duration of surgery have been linked to higher risk of causing or higher risk of surgical site infections. Back home in Nigeria, a study from Kano reports a rate of 9.1% among women undergoing cesarean section. And 4 factors were linked to higher incidence of surgical site infection. And these factors include duration of labor. Women with prolonged labor had higher risk of surgical site infection at the cesarean site, at the abdominal site of cesarean section. Women who had intraoperative hemorrhage, women with intraoperative bleeding, intraoperative hemorrhage that required transfusion or who were transfused, and women who had longer surgery. All these factors were related to higher incidence of surgical site infection. Another Nigerian setting found a rate of 25.6% of surgical site infection, which is higher than quoted here. And that's another thing that I want us to think about. Our own setting, we tend to have higher infection. And patients who had Kashner wire, orthopedic patients who had Kashner wire inserted for them during their surgery, had 75% of them actually had surgical site infections. Another risk group was women who were having mastectomy, as a 43% surgical site infection rate was found in such women. What are the other risk factors? Other, hip prosthesis. Another study found hip prosthesis as, having a 2.5% odds ratio. 3 surgeries: hip prosthesis, large bowel surgery, and vascular surgery. If you look at these 3 surgeries, 2 of them have direct access to cavities: the vascular cavity, where infection can be borne around the body easily, to the bowel, where microorganisms reside, and prosthesis, which is also a risk factor for infection. Classification of wound. Here, the type of wounds can be a risk factor for surgical site infection. Contaminated wounds and dirty wounds. Contaminated and dirty wounds are high risk factors for surgical site infections. What is the interplay? An interplay of the surgical procedure, the host, that is the patient, and presence of microorganisms, determine the establishment of surgical site infection. If you look at microorganisms here, the number, the virulence, and if you look at it, we have not put here the ambience of the surgical environment. The microorganisms, that will determine the number of the microorganisms present. So, organisms causing surgical site infections: 2 major organisms, Staphylococcus aureus and Escherichia coli. Staphylococcus aureus, typically from skin flora, are inoculated typically from the skin flora of the patient, whereas Escherichia coli typically are inoculated from endogenous, that's within, intracavity, within the peritoneal cavity and bowel, or cavity, genitourinary tract and respiratory tract. Those areas where the organisms may actually be residing can actually be translocated from those areas to the wound site. Other organisms that are infecting instruments could be mycobacterial organisms and non-mycobacterial organisms. This is when we are dealing with our surgical instruments, implants, instruments that we use, especially instruments that have several parts and crevices where microorganisms could hide. Other surgical risks: surgeries on sterile sites have less surgical site infection rates. As sterile sites where there are not much organisms dwelling normally, where they don't reside normally, they have lower infection rates than sites where there's minimal access surgery has lower rates. Bones, joint spaces have less likelihood of surgical site infections than the colon, where bacteria are normally resident. Pathogenesis of surgical site infections: 70 to 90% are caused by patients' endogenous flora. I mentioned that earlier. And as little as 100 colony-forming units of bacteria inoculated into a wound can result into large infection or widespread infection, and the organisms are typically inoculated into the wound site at the time of surgery. So most of our preventive measures revolve around perioperative period. So exogenous sources could be surgical personnel who, carrying them in their bodies, or heater or cooling system within the theater. All this can transfer microorganisms into the surgical site. I hope I'm still communicating. I hope I'm still online. So if we look at the factors that determine surgical sites, most of the factors are modifiable factors. Most of the factors that we have are modifiable factors. I hope you can still hear me. Now, the only few are non-modifiable, and these are age. We know that older patients tend to have loss of subcutaneous tissue, and this can depress wound healing and allow, spread of infection. And patients who have had history of skin or soft tissue infection can also be risk factors. Then patients who have had radiation therapy tends to destroy tissue and impair wound healing around it. The modifiable factors include these premorbid chronic illnesses like diabetes mellitus. Hyperglycemia tends to impair innate immunity and promotes glycosylation of proteins. Proteins that are required to encourage healing and destroy bacterial tissue are glycosylated. These proteins are no longer available and wound healing is impaired. Patients who are obese, obesity diminishes vascularity and distorts blood supply to the wound site. Patients who are on immunosuppressive therapy, the inflammatory phase of wound healing will be impaired. Patients who are malnourished, there will be no diminution of nutrients that are required for wound healing. Tobacco use causes vasoconstriction, which could impair blood supply and oxygenation of the wound site. Patients who have perioperative infection should be treated before they are taken in for surgery. Contamination, airborne contamination is another important factor. This raises the amount of oxygen. So the operating room ambience has to be looked at, the cooling system, the number of doors, the number of windows, the entry, passage of human beings in and out of the operating room. It needs to be regulated. Anticoagulation can cause oozing, continuous oozing of the incision site, and the risk of seroma in the incision site is there. Blood transfusion can cause or can impair macrophage activity. Foreign material also stimulates inflammation at the surgical site and raises the risk of surgical site infection. Persistent inflammation can cause oozing of fluid and delayed wound healing. The longer surgery causes longer exposure to theater ambience, risk of contamination, and risk of wound infection. Perioperative hypothermia is another very important. I'm stressing this factor because in the prevention, we're going to look at these factors one after the other, and those are the factors we're going to address in preventing surgical site infection. Perioperative hypothermia will cause vasoconstriction, and this will cause impaired tissue perfusion, impaired oxygenation, impaired delivery of proteins that are required for wound healing. Postoperative hyperglycemia alone, even in the absence of patients who are diabetes, is another important factors. Impairs neutrophil chemotaxis, impairs bactericidal activity, and phagocytosis are also impaired because of the high level of glucose there. The surgical technique is very important also. Retention of the vitalized tissue within the patient's body can slow down wound healing and act as a nidus for infection. Rough manipulation of tissue leading to ischemia, inadequate blood supply, or drains that are not placed in proper places can result in retention of fluid and wound infection. Wound care is very important too. This is another area, postoperative wound care. What kind of dressing did you place on the wound? All those kind of things. Contamination from patient's own flora, we discussed this earlier on, and wound contamination from the OR personnel, and wound contamination from instruments are important areas that we need to look at as well. Now, three things are present when a patient has ASA 3 and above, or the operation site is classified as contaminated or dirty, or the operation lasts more than 75% percentile for the normal duration of that surgery. Then we score 1 for each of these. And based on the score, that will determine what we'll do for the patient and classify the patient as the risk for infection. Now, this is just classification of surgical site infections. I mentioned that earlier. We have superficial surgical site infection, deep surgical site infection, and organ or space surgical site infection. Here is just the diagram on the right is just showing, the layers that are involved. We have the subcutaneous tissue involved in superficial surgical site infection. We have the deep tissue involving muscle, and we have the cavities or organs involved in the organ or cavity or space surgical site infection. These are just in examples. My cursor is on the image on the left. The upper image on the left shows this is just superficial. These other two are deep. They're involving the muscle. They are reaching up to the muscle. While this one is organ or space specific one involving this patient had bowel surgery and developed pus within the peritoneal cavity. Imaging showed there was pus within patient. The surgeon has to go back and drain the exudate within the peritoneal cavity. So it's an example of such. How do we prevent surgical site infections? That's what brought us here at this presentation today. I'll be using the WHO model, which talks about, perioperative bathing. Many of these things we know, but I just want to highlight some very important areas that maybe there are updates and, in the WHO module. Preoperative bathing, we all agree with that one. Bathing with a soap containing solution helps to clear organisms from the skin of the patient. Hair removal, this is one area where the WHO, you'll soon see the highlights of it. You can see there is an X on it. The WHO discourages it as much as possible. Surgical hand preparation, very important. We do that one every time. I'm not here to take us on that one. Surgical site or skin preparation, very important. There is an update on that, comparison of chlorhexidine gluconate with alcohol versus povidone iodine. I'll talk about that briefly when we move on. Preoperative surgical antibiotic prophylaxis. This one too is another very important area that is raising a lot of reaction all over the place. How much dosing and for how long should surgical antibiotic prophylaxis? You'll be shocked by what the WHO recommends. Here, use of grounds and drapes, have been shown to be protective. And OR discipline is a very important one. The inflow and outflow of individuals into the OR, the materials that can be brought into the OR, the number of doors in, the number of windows, the ambience, the airflow within the OR is another very, very important, factor to consider. Okay, I've mentioned this one, environmental cleaning. What can be done inside the OR? Your processing of instruments. Sometimes you want to start your high-level disinfection within the OR. What kind of instruments, what kind of processing can be done inside the OR? So that has to be considered, so we don't have nosocomial spread of infection to other patients. Surgical antibiotic prophylaxis is appearing here again. The WHO, you can see another X here. WHO discourages prolonged use in patients who don't have risk, or routine prolonged use of surgical antibiotic prophylaxis. The cause of, you see the reason soon. We talk about this one, decontamination and reprocessing of medical instruments, very important preventive measure. We should be able to know which instruments require sterilization, which instruments require high-level disinfection, and even in the high-level disinfection processing, each step must be followed to prevent surgical site infection. You must first dismantle the instrument, decontaminate the instrument, pre-clean, clean, rinse, and package properly. And when done, you have to store. All these steps must be followed, or else the instruments could be sources of infection for the patient. Very importantly, this is another important update area, the wound dressing. The WHO has something to tell us on the type of wound dressing that is recommended for us. Now, I'll just go straight to the point here now. Hair removal versus no removal. The WHO discourages removal of the hair, and if it's important, if there is need for it, maybe the hair is going to disturb your incision and it's going to, it's so much and it's fluid and impair or delay operation time, you can remove, but it should not be done in the OR or on the OR table. It should be done in the holding area before moving the patient into the OR. Very important. And what do you use for hair removal? Infection rates have been shown to be highest with razor than clipper, than depilatory creams. So all these have to be looked at. Removal with razor is discouraged by the WHO because it produces micro cuts, small cuts on the skin in which organisms can actually hide and they grow later and infect the wound site. Decolonization is very important, especially for high-risk surgeries, especially working in cavity in the respiratory tract, in cardiothoracic surgery, orthopedic surgery. Those areas you want to first put, for instance, in the respiratory tract, you want to put intranasal, intranasal agents, drops of anti-staphylococcal agents inside that area to clear organisms before surgery is done. The same thing in cardiothoracic surgery and orthopedic surgery. You want to clear organisms before you, take on your surgery. Antimicrobial prophylaxis, is accepted for all patients, all cases of surgery. However, single dose is recommended today, and that single dose should be given within 60 minutes of incision. Prolonged antibiotic use after surgery has been shown to have a high risk for acute kidney injury, and in fact, resistance could breed, which could be a community health problem later on. So WHO recommends do not continue antibiotics after wound closure. The antibiotics should be given at incision and within 60 minutes of incision and not thereafter, unless there are other risk factors present. Surgical safety checklist. This one is very, very important. This is one practice that I have come to embrace, I have come to love. It has been shown in quasi-experimental studies that the surgical safety checklist, surgical site infection rate in surgeries done with the checklist is 3.4% compared to surgeries done without the checklist. That is significant, excuse me, I need to move. Okay. Now, other intervention includes skin preparation. This one is another very important area. Use of chlorhexidine, gluconate, and alcohol. Chlorhexidine and alcohol, Savlon, then alcohol, compared to povidone, iodine, and alcohol. The infection rates are what we are seeing here. Surgical site infection rate has been found to be lower. Hello, I hope you can still hear me now. Hello?
Yes, we can.
Yes, we can hear you, sir.
Hello? Oh, thank you. So surgical site infection rates have been shown to be lower, 9.4% compared to 16% when povidone is used. I'm sure a lot of people will be shocked by this. Our most beloved, is it betadine or povidone iodine? Now, temperature control. We said earlier on that hypothermia causes vasoconstriction. We can impair blood flow to the wound site. We can impair oxygenation to the wound site. So hypothermia has been associated with a higher infection rate, surgical site infection rate. So we must do everything to maintain patient's temperature. We use warm fluids. We keep the patient covered. And we maintain the temperature. We have to regulate the use of air conditioning system within the operating room and use warm fluid to prevent hypothermia in the patient, because that too is a risk factor for surgical site infection. Now, blood glucose monitoring. Regardless of whether the patient is diabetic or not, it is now standard practice by WHO and recommended that all patients must have their blood glucose monitored during surgery, because it has been shown that hyperglycemia causes a lot of problem, impaired wound healing, impaired macrophage action, impaired neutrophil chemotaxis, glycosylation of proteins required for wound healing. All that will impair wound healing and increase the risk of surgical site infection. In fact, in patients whose glycemic control were monitored versus conventional, it was found that patients who has their glycemic control less than 150 milligrams per DL, and among those who had conventional management, that is, they were not screened, they were just taken in, some of them were found to have blood sugar levels greater than 150 milligrams per DL. And in fact, infection rate is higher in them, 16% compared to 9.4%. Now, blood glucose control should be maintained within 110 and 150 milligrams per DL to prevent hypoglycemia and to prevent hyperglycemia in the patients on the table. Wound dressing, this is another interesting area. Incisional negative pressure wound dressing, versus the standard wound dressing, has been shown to reduce surgical site infection rate to 9.7% compared to 15%. This was found in the meta-analysis of 23 studies, 23 randomized control trials, and it was found that a significant difference was found in negative pressure dressing. I don't know how many of our centers do negative pressure dressing, but it has been found to be very, very, useful. This prevents fluid from accumulating on the incision site, and it maintains pressure in that wound site lower than atmospheric pressure, so that whatever comes out is sucked away, is taken away from the wound site, and is not allowed to stay there. So microorganisms cannot multiply there, and the wound sites are kept opposed, and there's nothing distracting them. This is another important finding. Recommendations. This another very important thing that is being done today, recommended in many centers, is having a surveillance team, hospital infection surveillance team. And this study, Senec study in the US hospitals, have been shown to significantly reduce, infection rates in many of the US hospitals. An infection control committee, I don't know how many of our hospitals have them, but we have in our center, should be set up and should compose of healthcare workers who have been trained in this. Their task is to identify high volume and high risk procedures, high volume procedures that you do every time, and high risk procedures, that can risk surgical site infection, and collect data from this and find what are the infection rates, what are the factors that determine infection, and give a report to the stakeholders to take action on future prevention of surgical site infection. And this also is important. Whatever action they take, whatever is done, feedback should be given to the surgical personnel on what to do to prevent surgical site infection. How does surgical site infection present? Typically, for staph aureus, typically presents 14 days, within 14 days after a plastic surgery, within 24 days after orthopedic surgery, and within 28 days after orthopedic surgery where an implant or prosthesis was used. Now, these are just how they present. Typically, signs of infection, we have defined it earlier on. Signs of infection: inflammation, redness, pain, warmth, and there may be exudates, and there may be limitation of activity in those areas. Now, deep organ-specific infection don't manifest very early. In fact, many times it is imaging, ultrasound scanning, CT scan, or when it now spreads to deep and spreads to superficial, that's when it becomes obvious many times. However, post-operative fever can be, a feature that we can use to suspect it. Now, treatments. If we look very well, all these preventive measures and compare it with the cost of treatment, prevention always is better than cure. And management involves, using the score, like I said earlier, we can anticipate patients who are likely to have infection. When it happens, you need to evaluate and determine what to do or what antibiotic to use. Swab is very important, and swab, there are specific ways of taking swab from a wound site. You should not take the exudates from the wound site. You try and clean the area, make sure that whatever sample you are taking is representative of the organism so that the correct organism can be cultured. Biopsies may be needed in some instances, and imaging is very useful, especially when dealing with deep organ-specific or cavity or space involvement. The treatment involves non-surgical treatment. Patients who are presenting early, you want to give antibiotics, you want to give analgesic, anti-inflammatory agents to, that's based on culture. After considering your culture result, you can do non-surgical treatment before a surgical treatment and afterwards. Antibiotics should be carefully chosen. Then surgical treatment is important in some instances, where you have collections within the wound, where you have collection within the body cavity, pus within the peritoneal cavity, or where you have the recent wound in which the edges are widely separated and you want to come and repair, or where you have fasciitis and you need reconstructive surgery for such. This is just to showing what to do as management of surgical site infection. You need to evaluate. This is a stump. Patients that had amputation, this is a stump that is being infected. Microbiological culture swab is being taken. This is a patient who has surgery involving the use of an implant. In that instance, such implant, when there's infection involving implants, such implants need to be removed before treatment, will be taken. This is just a nutshell of what an update of what we know already. So if we look at patients going through this, patient has to go through this evaluation, go through treatment, this cost is much more. The cost borne here is much more than what would have been borne to prevent it. Cost to the patient, emotional stress to the surgeon. And in fact, in conclusion, I want to say that surgical site infections are an unwanted complication that could be debilitating for the patient and frustrating for the surgical team. They have potential to undermine the benefits of the surgery, and you all agree with me that they are better presented. So I want to thank you. These are my Thank you for listening. These are my references, and I want to thank you for your rapt attention. Thank you very much.
Thank you so much, sir. Thank you. That was very, very, very educative and enlightening. Thank you. Mr. Destin, I have something to say.
Not that I just want to appreciate Prof for the beautiful presentation. Really very, very insightful, well packaged, and very loaded. And Prof is very, very, very good in teaching. Prof, thank you very much, sir.
Thank you so much.
Thank you very much. Yeah.
Thank you for having us.